it's a case of a patient who was actually a pilot, and he was referred to us because he had a left bundle branch block. Basically, I think most of you are aware of the fact that pilots have to be very healthy to be allowed to fly. And so he was checked very, very thoroughly, and he never had any problems until during one checkup, he had this left bundle branch block during his ECG. So I'll be showing you this case now, the echo that we performed with him. And I want you to just follow along and take a look especially at his left ventricular function. Okay, so what you see here is the parasternal long axis view. I'll try to give you more gain so you can really appreciate this view here. Just for review purposes, left ventricle, you have the right ventricle here. This is the aortic valve. Here we have the mitral valve, the left atrium. This is now the short axis view. Okay, remember, these images are very important for you to really look at closely, because after all, if you write a report, you kind of make the decision if the pilot is allowed to fly or not, because obviously you would not want to have a pilot who has reduced left ventricular function flying a jet plane. And the pilot I'm talking about was flying long distance with a very large plane. So a lot of responsibility. I'm not going to give you my opinion, but I want you to just take a look at his left ventricular function first before I tell you what I think about left ventricular function. What we performed here are some measurements showing the size of the atria, which are basically normal. Okay. This is again another 4-chamber view. We performed measurements of the size, just a very brief measurement here, 53 millimeters, which is actually normal size for this patient. He had a body surface area somewhere in the range of 2.2. He was very athletic and participated in a lot of sports. And this is the short axis view here, and this is the apical long axis view. Remember, you have to really look at all the different views to get a good estimate of left ventricular function. Okay. You can also take a look at his regional wall motion. Maybe you think he has a regional wall motion abnormality. Okay, so I'm going to ask you a question now, and I want you to tell me what you think left ventricular function is like. Hope you can see this now. Okay, so you have the possibility to actually answer this question. How good is left ventricular function? Okay, so what we have here now is we have 20% think left ventricular function is normal, 20% think it's borderline, 40% think it's mildly reduced, 20% think it's moderately reduced. Okay, so most of you actually think, okay, something is wrong, or at least 60% of you think that left ventricular function is reduced. Okay, now, this would actually mean that most of you think that he should quit flying. Well, what we actually did with him is we performed a calculation of the Simpson ejection fraction, and what we got was an ejection fraction somewhere in the range of 52, 53 maybe, but we kind of tailored it towards 56 because we still thought it was kind of normal. But we also did other tests to show us how good left ventricular function is. What we did is we performed a magnetic resonance imaging, we performed a nuclear scan, and we also performed angiography because we wanted to be sure that the patient does not have coronary artery disease. And with all the different methods we used, what we got was actually an ejection fraction very similar to what we got with echocardiography. I would say borderline to mildly reduced. Okay, so the question now is, what do we do with this patient? Does anybody have a clue? Does anybody have an idea? Are there any suggestions? Okay, well, I'll tell you what we did. We said, okay, now he does not have coronary artery disease. He has no risk factors. He had a treadmill test with an exercise capacity somewhere in the range of, maybe 130 or 150%. So he was very, very good on the bike. And he had no arrhythmias. We even performed electrophysiological stimulation to rule out that he has some form of arrhythmia. And we said, okay, let's let him fly. And that's what we did. And okay, he was off. And we didn't see him until he came back for his yearly exam. And the next thing I'll show you now is the next exam we performed, which was in 2008. Okay, so this is the next study I'm going to show you. And again, I want you to tell me how good left ventricular function is. I'll start out with the parasternal long axis view. This is the long axis view now. The atria, the size has not changed very much. Again, 51, approximately the same size of the left ventricle. Again, short axis view. And now let's take a look at first the four chamber view. Okay. Has anything changed? Well, again, I'd like to ask you the question, how good do you think left ventricular function is now? Is it reduced? Well, if you look at the left ventricle now, you can note that it's actually normal. We have completely normal contraction pattern, no regional wall motion abnormalities, and when we performed the Simpson ejection fraction calculation, we got something in the range of 65%. But what has happened? Why does the patient all of a sudden have a completely normal left ventricular function? Well, the reason is very simple, because he does not have his left bundle branch block anymore. You can see that here at the ECG. There's a normal QRS complex width. You don't see any dysynchrony anymore. And therefore, left ventricular function is actually better now than it is. But the big question is, well, what does that actually mean to have a left bundle branch block? Let me go back to the previous exam and show you the previous loop again. Let's take a close look at how the septum actually moves. The problem we have here is that the septum moves very desynchronous, especially compared to the lateral wall. I'll turn down the speed here. You can see that very nicely. You have an inward motion of the septum, then you have an inward motion of the lateral wall, and then again an inward motion of the septum. So the problem that we have to start out with is to define when is systole and when is diastole. So this will also make it difficult not only to calculate the ejection fraction with the help of the fractional shortening in the M mode, but also with 2D imaging. So in other words, with a left bundle branch block, we will always underestimate left ventricular function. The question remains, why does the patient actually have a left bundle branch block? I mean, remember, everybody who has a left bundle branch block should undergo further investigation, not only pilots, but certainly everyone. Because you could have coronary artery disease or hypertension or dilated cardiomyopathy. But we don't really know why he had this. He had recent episode of sinusitis, but he never really had any myocarditis or infection of the heart that was really documented. Okay, but the story is not over. I just want to go back to the second study. The interesting thing was that we also performed a so-called strain analysis in this patient. A strain analysis is a special form of analysis where we look at longitudinal function. And all of those who have watched the course before know that it's a very important exam because it does show you early dysfunction of the left ventricle, because the first thing that really starts to deteriorate if you have a contractile problem is longitudinal function. And if we take a look at his longitudinal function, we can see that it's not normal in all regions. Certainly this cannot be attributed to bad image quality because his image quality is superb. If you take a close look, you can see that these regions here of the septum have a poorer or less good longitudinal function. What does that mean for the patient? Well, at the moment, not very much, because there's no evidence or no facts that allow us to determine if you could fly or not, just simply based on longitudinal function. It's probably still too early to use this in a clinical decision making. But the story is still not over, because I want to show you the study we performed in 2009, 1 year later. Okay, so again, this is the image of the patient. You remember what we saw in the image in the study before, 1 year before, where we saw no bundle branch block. Now again, he has bundle branch block. And we see that left ventricular function now is, again, rather poor. We see an abnormal septal motion. The left lateral wall seems to be doing okay. And let me just show you how large the left ventricle is. Just trying to find here the end diastolic frame. Okay. Okay, so somewhere in the range of 56. Now it's a bit larger than what we had before. Not very much larger, but if we performed calculations of the volume, we started to notice that his ventricle was just slightly getting larger. Okay, another 4-chamber view to help you appreciate left ventricular function. Another short axis view. Here, this is probably better because you can nicely see the abnormal septal motion. Okay. And then we performed a strain analysis again, and take a look at this. Now, the contractile function is even worse, especially here in the lateral region, in the septal region. And the global longitudinal strain is minus 13.7. So it started to drop even more. We have compensatory function here of the lateral wall, but global longitudinal function has actually dropped. Now, what did we tell the pilot? Well, he was still doing fine. He had no symptoms. He was doing perfectly okay. He was actually still very, very good with his exercise capacity. As a matter of fact, he was now also much into mountain biking and other extreme sports. And he said, well, I don't have any problems. Why can't I fly? And we talked back with the authorities and decided, okay, we'll just closely check on him and let's see how he's doing. But at this point, we'll still let him fly. And the study we performed next was in 2010 and one in 2011. And I'll show you just the last study we performed, which was in 2012, just to give you a feeling of how he is actually developing. Okay. This is now his peristernal long axis view. Another peristernal long axis view. Short axis view. Okay. Another 4-chamber view. Okay. Okay. And now I want to ask you a final question. This is the question where all of you have to answer, and it's a very simple question. Would you fly with this pilot? Okay, so this is a very critical question. Well, then I'll tell you what the results are. 54% of you say yes, why not? 23% say no, definitely not. 8% say it depends on how he looks, and 50% say I don't fly, which is probably the wisest decision of all. But I'll give you some more background information, and then I'll tell you what we did. Well, the problem was that a lot of things were turning to the worst. First of all, the left bundle branch block was getting wider. He now had a QRS width of 175, while he started out with a width of something like 150 milliseconds. The second thing was he actually started developing an elevated BNP. And the third thing was that there was a lot of discussion of pilots getting paid and what their wages are. So we talked long with the pilot and tell, you know what, the best thing probably to do is take your compensation, leave the airline, and find another job. And that's actually what he did. In reality, we don't know if this decision is right or not and what the risk really is. But at this point, I have the impression that he is really turning into a dilated cardiomyopathy because we do see progression. What is the key point that I would like to make in this case? Well, I think one of the key points is that left ventricular function appears to be worse than it is if you have a left bundle branch block. The second problem is we do not know if left bundle branch block is actually the cause of dilated cardiomyopathy or the result of cardiomyopathy. My personal feeling is that left bundle branch block can actually lead to myocardial dysfunction, and that this can actually lead to cardiomyopathy, and that this is probably the problem that this patient has. My personal feeling is that it would probably be wise to implant a CRT system in this patient. However, I'm still very hesitant because he's very young. He does not have any symptoms at this point, but we're following closely and see if we were going to do something more in that direction maybe in the future.